So what do we do if we're in these different categories? What are our treatment choices? Well, if it's a low risk cancer, just get it out and it's taken care of. It might be a surgery. It might be for a basal cell, what we call an ED&C, an electrodesiccation and curettage, essentially just burning it off. If it's in one of those problem areas, the nose, the face, the ears, the hands and fingers, where we can't do a wide surgery, but we still need to get that cancer out, this is where we might want to think about a Mohs surgery. This is just zooming in on that part of the pathway here. Mohs or other forms of PDEMA. What on earth does that mean? I don't even remember what it is, um, what it exactly stands for, but it's peripheral and deep excision with margin assessment, meaning you got to look at all of the edges. Okay, the advantage of Mohs compared to standard surgery with wider surgical margins and postoperative margin assessment is that the Mohs surgery approach can let you get a smaller surgery size and still get the cancer out. Number one. And number two, that the Mohs procedure allows you to tell right then and there, while the surgery is going on, whether you have reached the point where the margins are negative. In contrast, the surgery approach, the standard surgical approach, which is what I do, I'm a surgical oncologist, not a Mohs surgeon, usually starts with a wider margin than we might start with a Mohs procedure. Not always, sometimes they're the same. But we take it out, and if we don't see anything with our naked eye, we send it to the pathologist, and it may be a week or two before that pathologist tells us whether the margins are all clear. As long as we've looked at the margins carefully and they are all clear, we've usually cured the patient. But with Mohs, we might get those clear margins with a smaller, narrower amount of tissue being removed. And we might know that right then and there that day. Get a lot of questions about what exactly is Mohs. It is Mohs. Frederick Mohs was a dermatologist who invented a technique and a technology where when you took out a small amount of normal skin around the cancer instead of a wide amount, you could put all of that onto a microscope slide and look at it under the microscope and map it out. Micrographic surgery, meaning you used the microscope as part of the procedure to make sure that each portion of what you removed was free of cancer. And the Mohs surgeon, rather than the pathologist, is the one who's looking at the slide during the procedure while the patient is waiting there and coming back and saying, okay, well, you did pretty good in one place, but we missed it, and we still have cancer in another. The visualization that I like for this, any of you ever eaten a Reese's peanut butter cup? It's a chocolate candy. It comes in that wrapper, and the wrapper doesn't cover the top, it covers the sides and the bottom. When you peel that wrapper off, at least the way I do it, there's almost always some chocolate left on the wrapper. Is it on the sides? Is it on the bottom? It's never exactly in the same place. Is it a little bit over here and a little bit over there? Mohs surgery is essentially peeling the wrapper off around the skin cancer, flattening it out, and looking at it under the microscope and saying, okay, right here at this part of the bottom, near the 6 o'clock margin of the bottom, there's a little bit. And over here, up there by the 2 o'clock part of the wrapper on the side, there's some cancer cells, some chocolate. Now, only those two areas am I going to go back and take some more and put that new piece under the microscope until I don't see any more cancer left behind. But that first Mohs surgery, the Mohs invention was, how do I take that wrapper, flatten it out, look under the microscope?